and on how aggressive you are going to be in terms of revascularization. For example, some techniques, retrograde through epicardials, have more risk than other techniques. So everything needs to be taken into account to make sure that whatever you're doing has more benefits than potential risks. Everyone is asking about randomized trials, and there are some, not many, but there are 6 randomized trials in CTO PCI. EuroCTO was the largest European study. Patients with single vessel CTO, so you had to have everything else fixed before you undergo in this part in the study. And what it showed is if you undergo CTO PCI, you had better quality of life in terms of Seattle engine questionnaire than if you don't. And this was shown to be persistent on 1 and 3 year follow-up without increase in MACE. In contrast, the Korean study called Decision CTO, which included patients with multi-vessel disease with CTOs as well, so a little mixed bag over there, and also had 20% crossover. So 1 in 5 patients who randomized to OMT, medical therapy, went over to CTO PCI within days after getting randomized. 2 small single-center randomized trials showing the same thing, better exercise capacity and better quality of life, and 2 studies for EF improvement, both negative. How about the ischemia trial? As you know, ischemia was one of the large trials in people with chronic coronary syndromes. There were quite a few patients, almost 1,500 patients who did have a CTO. And for those patients, similar to the main study, there was a reduction in spontaneous myocardial infarction if you did CTO PCI, and symptoms were significantly better in those who underwent CTO PCI. So very consistent symptomatic improvement and maybe some prognostic improvement in terms of reduction in spontaneous myocardial infarction. That's at the cost of having more procedural myocardial infarction. So well accepted, the principal indication of CTO PCI is to improve symptoms. Some people have more generalized symptoms. For example, this study from Bobby Ye showed that patients with CTO often have depression symptoms. And by fixing their CTO, not only their angina improves, but their depression improves as well. Here are the contemporary outcomes: success 85 to 90%, MACE, and we're between 0.5 and 7%, around 3% is the average. So it's not perfect.
This is in hospital MACE?
Correct. This is a hospital MACE. For the long-term follow-up, you have 5 to 10% ISR, but the long-term depends a lot on your baseline characteristics, right? If you have a 90-year-old, it's a different MACE than the other ones. But this is all in hospital events. But the problem is, what you saw before is in experienced centers like yours. When it comes to overall population, if you look at NCDR, that's old study, but this hasn't changed that much. If you look at overall centers, the success is still pretty low and the MACE is higher. So it's not necessarily that everyone gets this 85, 90% success. In the general population, the overall cath labs, operators who do 2, 3, 4 CTOs a year, well, success is not that high and the complication rate is much higher than it is. So again, this is something that should be done at experienced centers. This is from BMC in Michigan, Blue Cross Blue Shield, exact same thing. The more cases you do, the better success you have and the less complications. Like everything else, the more you do, the better you get. So we do need to have more experienced operators. So any of you who is interested, that's the one area that people don't have a hard time finding jobs. If you do structural, it's going to be much harder. If you do CTO,
stuff.
you're going to have a lot more job offers than otherwise.
Yeah.
So if you want to learn, again, it does take time and effort. It takes teaching, can be done through a dedicated fellowship or through proctorships. Doing is the best way. If you don't do them, it doesn't work out. You cannot do this in structural, peripheral, I mean, you have to focus to some extent. And then keeping the process going and remaining motivated is a key part. Now, if you have CTO and you are unlucky enough to have an MI, and this is for STEM, but applies the same for non-STEMI, your short-term mortality is going to be higher, and you're more likely to develop cardiogenic shock. Also, you're more likely to have out-of-hospital cardiac arrest. The reason is that if you have an MI and you don't have other significant occluded vessels, then the ischemia territory is X. But if you have a CTO and then you get an MI on the non-CTO vessel, your area of ischemia is exponentially higher. And that results in cardiogenic shock. That results in more out-of-hospital cardiac arrest and worse outcomes. This doesn't necessarily mean that you have to open everything because you don't know if a patient will or will not have MI, but that adds to the potential indications. Also, many people are saying, well, yes, my patient has a CTO, but has great collaterals. So why bother? Because the collaterals are doing the job. And the answer is, if you actually drop a pressure wire, this is after crossing the CTO, dropping a pressure wire and doing an FFR, well, pretty much everyone is going to be ischemic. So when you have a CTO, even in the best collateral circulation, you're still going to be ischemic in the area supplied by the occluded vessel. These are some rare cases. This is a case of recurrent VT that was not responsive to medications, and when the patient was revascularized with CTO-PCI, the VT stopped recurring as well. And we do know that if you have a CTO and cardiomyopathy and an ICD, your incidence of appropriate ICD shocks is much higher than if you do not have a CTO. And also, there are some preliminary data that if you revascularize the CTO, there's some good, not only mechanical, but also electrical remodeling that could potentially reduce your future risk for ventricular arrhythmias. But again, as I mentioned, the number one indication remains the symptoms. And this is another example of where CTO-PCI can be useful. These are patients with ischemic cardiomyopathy. This is more acute setting than chronic setting. As you know, BISIS-2 did not show much benefit for revascularizing chronically patients who have cardiomyopathy and are stable and do not have any occurrence. Most of the patients we do with cardiomyopathy are done in a semi-acute or acute phase when they present. So this is a patient, significant left main disease, and then he has a CTO of the circ and some diffuse disease on the right coronary artery. As I mentioned, two trials, the EXPLORE, which was in the setting of acute MI, PCI of the CTO within 7 days versus not, no difference in ejection fraction by MRI at 4 months. This is the Revasc from Germany, same thing. The caveat there on both studies is that the baseline EF was around 50%. So those patients did not really have significant reduction in ejection fraction, and that might be in part why you don't see the benefit. In contrast, if you do it in patients who have more decreased ejection fraction and viability, then they're much more likely to have an improvement. So in this patient, the LAD left main was fixed, the circ CTO was revascularized, and the ejection fraction did significantly improve a few months later. The other thing here is the ejection fraction may take 3 to 6 or even 9 months to recover. So this doesn't happen overnight. It's a gradual process over time.
And probably Impella made the difference also during that revascularization.
Yeah, absolutely, yes. I mean, those patients who have essentially, this patient was having, depending on the right, for most of it, and yes, support really very important. And I think the threshold for Impella has really decreased in recent years quite significantly. This is another case. This is a patient with a vein graft. And we don't see them as much now. I think the patients with bypass are relatively less, but we still see them from time to time. Comes in with acute MI because the vein graft is occluded. The vein graft is opened. There's good flow, but a lot of undilatable lesion. We know that this bypass graft, if your vein graft closes down and you open it, your chance of staying open it's pretty bad. It's going to be essentially more than 50% within the next couple of years. And we know that if you open the native coronary, your chance of being open down the line is going to be significantly better. And it's been out quite a while that, people were saying, well, maybe you shouldn't fix the vein graft, which will fix the CTO of the native, but in the acute setting, that might be very hard. So we don't do it in the acute setting because time is muscle. We don't want to really kill the myocardium. But this patient came 3 weeks later. We did have the time to get coronary CT to plan the procedure. We saw significant calcium on the distal area of reentry. So went back around the area of anterior expansion and got it open. I'm sorry, was that a question?
No, I think it was just a miss.
So this is the concept of staged vein graft revascularization. So you do CTO not as the first step. The first step is you open the vein graft, and then you let the patient recover, and then you bring them back, and you open the native coronary, having the time and everything else. So this is another example
this is interesting.
Where vein grafts, again, maybe not be the best thing to deal in the long term. And one more example of what it can be useful, the CTO PCI. This is a patient with inferior STEMI. Here is the culprit, a lesion on the right coronary artery. There are some previous stents on the distal right coronary artery. Trying to get through. Had difficulty with access, who lost access, held some manual pressure, got access on the other side. Trying to get through doesn't work. The patient is getting hypotension. Anyone can tell what is going on with this patient?
Retroperitoneal bleed.
So this is called a dented bladder sign. The bladder is supposed to be round. And as very nicely you said, what's happening here is you have something collecting in the retroperitoneal space in the pelvis that's pushing the bladder, and that's a retroperitoneal hematoma, again called a dented bladder sign. And the beauty of this is you don't need to go to CT. I mean, you're in the cath lab room, just fluoro the bladder. You see this, you know this is going to be retroperitoneal hematoma. And then sure enough, when you take a look, you see the perforation. It was a high stick. And then, of course, the treatment is trying to put a cover stent, which was not easy. And in the meantime, the patient goes into cardiac arrest. Defibrillation, placed on Lucas. It looks pretty desperate at this point, I must say. But somehow the vascular surgeons had made it at this time. They couldn't get themselves the cover stent either. But what they did is they cut down. They put the cannula in the IVC directly, which is something unique. And then the problem now is that they stabilize the patient in terms of bleeding, but there's still huge ST elevation. The patient keeps on going on VT-VF. So we need to open up this right coronary artery. And this wasn't easy, but by using what's called dissection reentry, and I will talk about this in a minute, you went around that area of dissection in the proximal RCA, got reentry into the distal true lumen, placed 4 drug-eluting stents, got the right artery open. He was able to be defibrillated, and miraculously, this patient actually did make it, and he was eventually riding his bike a few months later on. So this is the case where CTO techniques can help you in non-CTO PCI to take care of complications. And we do see, no question, many more complications in CTO PCI, so we get much more adept at managing perforations, equipment loss, acute vessel closure, you name it. So people get much more comfortable dealing with complications because it happens so much more frequently in CTO PCI. In terms of the guidelines, Class 2B on both the European and the American, there's the Orbita CTO, which is still enrolling, but hopefully we'll have some results soon. And there's some larger studies like the ischemia CTO trying to look at the question of MACE. In terms of techniques, how do you get this done? 2 major ways. You go undergrade or you go retrograde. And then you can either go from true lumen proximal to distal, or you can do what's called the extra plaque crossing. We used to call it subintimal. Now we call it extra plaque. And essentially, you get into the wall of the vessel and then you get back in. That can happen in the undergrade direction. That's called undergrade dissection reentry, or ADR, usually with the Stingray balloon or the recross. Or you go retrograde and do the same thing. That's called RDR. How do you choose how to start and where to go? This was the hybrid algorithm now 13, 14 years ago. You start with a dual injection, and then depending on the characteristics of the lesion, you choose undergrade versus retrograde. The key thing is to change. You don't do the same thing. If something doesn't work, you do something else. This is the global algorithm, the evolution of the hybrid a few years back. Same thing. You start looking at the angiogram. This is a huge lesson, not only for CTO, but for everything else. It's not an exaggeration. You spend probably 15, 20, even 30 minutes looking at an angiogram. And what you see after 20 minutes is completely different from what you see at 2 minutes or 5 minutes. There's something about analyzing the angiogram, going through scenarios, what can happen, and writing it down. When it comes to access, one of the hallmarks of the CTO operator is the dual access. I can tell you probably 1/3 of the failed cases we get were done with single access. Single access is not only a risk for failure, but also it's a huge risk factor for getting complications, especially perforation, because essentially you have no idea where you're going. The reason you are putting the second guide in is because the vessel distal to the occlusion is filling in most patients through the contralateral vessel. And if you don't inject on that vessel, you don't know if you are in the true lumen or not. Sometimes in bypass patients, you may use a triple injection or do a sequential dual guide in which you start with 2 and then you switch to another 2. But again, putting that second guide in, that's again, the second guide and microcatheter, the 2 hallmarks if you're doing serious CTO work. When it comes to the angiogram, what do we look for? Very simplistically, you look at the beginning of the lesion. Do you understand the proximal cap? How long is the occlusion, if they are calcium or not? That's number 2. Number 3, distal vessel. And number 4, do you have any collaterals? So 4 parameters: proximal cap, occluded segment, distal vessel, and collaterals. And then you can use those parameters to calculate the difficulty of the occlusion. It is a classic example. A new operator gets some cases organized. You go to the lab, and they have JCTO5, which is the most complex cases. So you want to understand how complex this is, and this is the right time for you to tackle that CTO, or is it something for later on or doing it with a proctor? Tapered is good, blunt is bad, calcium is bad, tortuosity is bad, long length is bad, previous failure is bad. And as you increase the JCTO score, your success goes down, but even though this happens in experienced centers, even the most complex, you do get about 80% success. But to do this, you need to use much more the more complex techniques. That's retrograde in yellow or ADR in light blue. So the more complex cases you're doing, the more likely you are to need those more advanced crossing techniques, which comes at a cost. And the cost is the complications. When you do retrograde and ADR, you do have high risk of complications, perforation, tamponade, and even mortality and acute MI compared to undergrade wire escalation. Another key factor, as I mentioned, apart from the dual injection, is to use a microcatheter. Why? It's easier to get better support. You can reshape your wire without losing access to the vessel. You know where you're going. Multiple types of microcatheters that can be used. You don't have to have everything, but it's good to have one representative from each category, one larger one like the Corsair or the Turnpike, a smaller one like the Caravel XS LP, an angulated one like the Supercross, a dual lumen, and the plaque modification one. New devices are coming up. These are new devices about turning that are going to be becoming more and more important. And we do have a pretty large armamentarium of wires, but it turns out you can do most of things with just a few 4 or 5 wires. And those wires are a polymer jacket, tapered wire, like the XT, Fielder XT, XTR is one of those wires. A polymer jacket non-tapered, like the Pilot, Fielder FCC or Black. Stiff polymer jackets like the Gladius, Gladius Mongo. And then the stiff wires like the Gaias, the Confianzas, and the Hornet. So 2 or 3 or 4 wires can give you a pretty large range of things that you can do. The Gaia are intermediate stiffness wires. As I mentioned before, this is probably our go-to after the polymer jacketed wires fail. And there are some stiffened wires that are coming up. This one is not available yet in the US, but it's coming. That is much more penetrating. The more penetrating the wire, the more likely you are to go into the wall, and the more likely to go outside, and the more likely to get perforation. So most people try to minimize the use of the very stiff wires just for very calcific proximal caps. New things happening are the use of what's called tip detection IVUS, using intravascular ultrasound to see where the reentry zone in and direct the catheter. That's very popular in Japan, but there's some penetration in Europe and starting in the US. There's another technique from Mauro Carlino, Salman Aren, called HDR. You may have heard it, very popular in the public media, in which you advance the microcatheter slightly in the lesion, inject 0.5 cc's of contrast, and then you follow with a polymer jacket wire, usually even without a bend, and the polymer wire will follow the track created by the contrast to get into the true lumen sometimes.
We have the meeting, Manos, remember, Sunday morning at TCT on the trial. Yes,
yes. So it is an exciting time about it. We'll see more, absolutely. And this is how it looks. This is how it looks when you inject the contrast. It's like the sparkle under the intravascular ultrasound. If you want to get in the wall, how do you do it? You do it what's called BASE, or balloon-assisted subintimal entry. Get a balloon, 1:1 or 1.1:1, microcatheter behind it, dissect the vessel a little bit, and then push a polymer jacket wire. This is probably the safest way to get into the wall of the vessel. You can do this on the main vessel, you can do this on the side branch, that's called the side base, and then you can form various knuckling wires. The knuckles is one of the things that is less intuitive for most operators, unless you're trained in CTO PCI, because we're taught to keep the wire tip straight and don't do all these knuckles. Well, in CTO, this actually can be the safest way, especially for long and tortuous segments, can be the best way to cross these long occlusions. And there are different types of knuckle. One is traveling in the vessel, the other gets stuck in one way, and then just the loop keeps on protruding further down. There are also different techniques if you need more support. For example, here you're trying to push through the occlusion, but you're just having a hard time. So what you do is you get a wire into a side branch and then get a balloon there. And that balloon provides you the anchoring and the extra force to be able to push the wire through the lesion without the things getting stuck. And this can be also done with a microcatheter. This is called tunnel in landslide. Ricky Santiago from Puerto Rico is the one who published this a few years back. And essentially you do the same thing. Balloon goes next to the guide extension and pins the guide extension. Now they have very, very strong support. We've actually done this to also deliver other things like cover stents or stents in very complex anatomy. We do have newer devices coming in, the Triumph from Teleflex, from Bill Nicholson is not there yet, but it's coming. There are other OCT-based devices to help you get back in. And what we're seeing is an increase in the use of what's called STAR. And STAR, or subintimal tracking reentry, is a technique in which you just literally push a knuckle wire all the way until it reenters spontaneously into the true lumen. Antonio Colombo, 2005, 20 years ago, published this for the first time. And it's now seeing a resurgence, not as the primary mode, but when everything else fails, this is one way to kind of get some blood flow in the vessel, let the vessel remodel, come back in a few months, and then see if the things are open. So this is an example, patient with an RCA trying to get in. We have a hard time, so we get a polymer jacket wire and we push the polymer jacket wire out. And you see at the end, you get flow, but the whole thing is dissected, doesn't look that great. But then you bring them back, and normally it's sooner than that, but this patient had some hard time. And now you have much less area of dissection. Things have healed quite a bit, and then it's an easy wiring and placement of stents. So STAR has really gone quite a bit. The Invest CTO, I think there will be something from it from Margaret McIntyre at TCT. So this is an area of active investigation. Some people are proposing it even as the first approach, especially in highly risky lesions with only epicardial collaterals. There's another study from CTO Plus that was just presented from Taisi Hirai about when you should do it. And it turns out that if you come back early, within the first 4 or 6 weeks, you have a little higher success, marginally significant, than if you come late after 10 weeks or so. So in general, bring people back before 2 months for those patients. Now, drug-coated balloons. This is an area that obviously Dr. Cortese has been the leader of, and there have been some early reports where this was done initially as an investment procedure. The STAR I showed you before, you do the STAR, and then get a balloon, drug-coated balloon, to go there, and that can prevent the vessel from closing down. Now, this now has expanded. And as you know, CTOs use some of the longest stent lengths than any PCI, the so-called full metal jacket. So the question was, can we reduce the length of the stent? Because the more stent you have, the more likely you are to have restenosis, stent thrombosis, and other complications. So several series have been published about using drug-coated balloons. This is one of them from Japan. Now, these are usually the easier CTOs where you do less dissections and more if you are intra-plaque crossing versus extra-plaque, but very promising result with TLR of 14% out to 29 months. And then this is from the European registry. This is from the European Registry of CTOs, showing that the uptake has been significant. It's been from 3% in 2016, now it's 15% of CTOs 2023 have been using drug-coated balloons. So it's happening. This has less stent length in general, less dye, and then in terms of perforations, complications, there was slightly less, which of course is probably just selection bias. If you have a complication, you're more likely to use a stent. But again, increasing use, and this is an area where it's going to go. This is the meta-analysis that you published just recently on 2,087 patients. And what was shown is that for target vessel failure, things were very, very promising. There actually trend for less restenosis in CTOs with DCBs. But again, the issue here is that it's not for everyone. And quite often, what's happening is it's not just a DCB, but it's a hybrid strategy in which you place a DES, but a relatively short one, and then you treat the remaining part of the vessel that is diseased with a drug-coated balloon. This way, you minimize the stent length, but still get good patency and tuck up any potential dissections. And then this is the co-CTO study. This is from Paul Kanapen in the Netherlands, in which he's randomizing patients to either just DES alone or a hybrid strategy of DCB and DES. I know that they've stopped enrollment, and hopefully we're going to have results soon. I think they have this year, they have the Proctor study, which was the opening the native vessel versus the vein graft in patients with previous coronary bypass. A couple other thoughts here about how much to stent. The myocardial bridges, this is where stents are really bad. So this is from CRF, from Akiko. MyHaram, if you stent into bridges, your risk of restenosis goes way up, 26%. And this might be the ideal environment for DCB as well. If you really need to do something for myocardial bridge, you definitely don't want any metal, and putting a DCB there might be the best way to go as well. In terms of calcium, very common in CTOs, and what's been happening is dramatic use, increasing use of intravascular lithotripsy. Now, as you know, we do have newer modalities, the Javelin, or part of the forward CAD. So this is more and more happening down the line. In terms of complications, CTOs are more likely to have complications than non-CTOs. Perforation is the #1 concern, but many other complications can happen. There are ways to predict the risk of complications. This is from Progress, the Progress CTO complication score. It's been done for MACE, mortality, can help you tell the patient, hey, your risk of a complication is 4% MACE, 1% mortality, makes the conversation a little more quantitative. For simpler CTOs, again, this is from the Netherlands, many people are sending CTO patients home the same day, especially with radial access. Again, that's happening increasingly, not for everyone, but I think we'll be seeing more and more of this as time comes back. No significant penalty in those patients, but again, carefully selected. If there's any question of complications, very complex lesions, those are still usually observed in the hospital overnight. The Ringer balloon, I'm not sure if all of you have it. It's a new perfusion balloon from Teleflex that can be used to stop the bleeding in a perforation while maintaining perfusion. You can deliver covered stents through it, so a nice armamentarium. The downside is it is hard to deliver. So if you have a very calcific, tortuous vessel, this might be tricky to get it down to where to go. It has also been used, this is from Lorenzo Angelini, for facilitating reverse cart, because it does give you actually a bigger lumen than a guide extension, so it can be used for reverse cart as the target for the retrograde wire to cross into the proximal true lumen.
If you are rich.
Correct. Yes, it's not cheap. I think it's more than 2K. So it is not something that you use lightly, let's put it that way. Otherwise, your administrator will probably, as you say, will probably call you and let you know about it. So in terms of complications, again, CTOs, you're going to have a lot of them. So the better prepared you are, the more alert, and then the more you know how to deal with them, the better it is. And there's books, there are many things that you can do. In CTO and everything else, there are two ways to get into a complication. One is forgetting to do something. For example, you are advancing a wire and you don't check your position with dual injection before you're advancing the microcatheter. Then you take a look, and of course, now you're outside the vessel and now you're perfed. So omitting the second guide lead to a problem. Or it can be doing something that you probably shouldn't have been done. And sometimes you do it consciously knowing it's a high risk procedure. Classic example, epicardial collaterals. High risk of perforation, high risk of tamponade. Before you tackle them, you should always ask yourself, okay, is this justified? Is this patient going to be better off if we do this or not? And typically, it's not just one thing, it's multiple things go wrong before you get a major complication. In terms of detecting the complication, you want to really be alert, because the sooner you see them, the faster you respond, the less problems you have. And the key thing is the EKG and the pressure. You should always, every procedure, but especially CTO PCI, do this all the time. In terms of treatment, you're going to have complications, no question. You call for help. Don't scream at the team. Keep yourself calm. Know your algorithms, how you treat complications, whether it's perforation, device loss, acute vessel closure, you name it. Know what to do. And then try to understand why this happened and what could you have done to make this better. Talk to the family. And again, this is one of the things that is the toughest probably in everything we do, having a major complication, talking to the family, but being honest and explain to them goes a long way, but also the same for the team. The team can get really stressed out and can be really frustrated and also depressed sometimes after some major complication happens. So debriefing and going over what happened can really come a long way, but don't forget yourself. Complications are going to happen. It's part of the game. Yes, they're going to take a toll on you, but the goal is to bounce back and move on, because guess what? The complication in this patient is going to be useful to prevent a complication in the next patient, and so on and so forth. A couple of words on CT. Pretty much 90% plus of the cases we do right now, we get a coronary CT. Granted, we do get complex cases, previously failures and everything, but it's amazing how much it facilitates your planning and your understanding of the lesion. You can see here, many patients now are coming without an angiogram. They're coming just based on the coronary CT. You can measure the aorta, choose your guides. You can measure the length of the stent, the length of the occlusion, look if there's calcium or not. You can calculate your JCTO score based on CT or some of the other scores. This is the AI QCT, automated AI-based analysis, automatic detection of the CTO composition. So this is happening more and more, and you don't necessarily need to be a CTO or CT expert. We're actually having a study in the planning phase right now in which AI QCT, so the automated analysis of the CT, is being used to help plan the procedure and make it faster and hopefully decrease complication rates and success rates. So this is something that you'll be seeing. We do a lot of courses on this, and it's happening. In terms of AI, it's not just for the coronary CT. Coronary CT is much more accurate than diagnostic angiography, but also you can predict the technical success of the procedure, and you can predict the undergrade wiring success. These are things that are hard to predict, but if you know you have a decent chance of undergrade wiring, that should be your default starting strategy for most lesions. And there's a lot of enthusiasm, but some concerns as well about the accuracy and the responsibility, who's going to be responsible for this. And then a couple of words, and I will finish about the operator. As you know, there is an epidemic of burnout in intervention and medicine in general. This was from a survey of CTO operators. 1 in 3 burned out, and a lot of depression there as well. And part of it has to do with the physical aspects. You do get much more radiation with CTO PCI, and we've seen a plateau in the radiation numbers. In ERCTO, there's some decrease, but again, there's some limits, at least for now, into how long can go on the radiation. And I don't know if you're lucky enough to have the Ramparts or the EGNES or the Prodecus in the world, but this obviously come a long way to decrease radiation and protect your back from doing this. I do use the zero gravity myself. That has really been a revelation. You probably have seen this film from David Ryzik about what you can and you should do. But it's not only radiation. Your blood pressure goes higher if you do CTO PCI. Your heart rate goes higher, though this is an unhealthy thing, unfortunately. So there's some stress involved. This was from a study we did in which we had a major complication while we're having heart rate monitoring, autonomic response, heart rate variability. This was the attending, this was the fellow. And of course, you have a spike when things happen. The goal is to not have repeat spikes down the line. The goal is to be able to kind of go back to baseline and function as effective as you can, because in this overstimulated states, you may not be the most accurate. And I think this is the definition of a master operator. You don't have these big swings, but you're much more level and calm and can deal through complications and through the challenges of CTO PCI. And this happens with time and experience and doing more and more cases. And there are many podcasts to help you with this. One of the things that's developing, there's a study right now we're doing in Europe with Claudiu Ungureanu, in which there's remote teleproctoring, and seems to be working fairly well. Not the same, of course, as being in person, but can really cover most aspects and be very, very useful, especially for people who are far away when travel is an issue. So in summary, CTO PCI is done mainly for symptom improvement. It is a difficult procedure, but you can get high success at experienced centers. DCBs are increasingly being used. Again, most as a hybrid approach, but I think we'll be seeing more and more of that, especially for the less complex crossing techniques. More coronary CT, more operators are needed. And again, this is an area of rapid development. So thank you so much, and we'd love to open it for some discussion.
Yeah, Manos, this was a really beautiful lesson. I don't know, in 45 minutes, how you were able to touch all of the areas of CTO, which is not only indication, not only technical, but also care of ourselves, which is very important. Because this job, if you do it for many years today, it can have an important and detrimental impact on yourself, on your mental status, and also on your physics. So it was a beautiful lesson, really beautiful. Unfortunately, we started the recording a little bit late, but I will review this very soon because I learned really a lot of things. So I think that there are questions, considerations by our team, and Ahmed is raising his hand. So let's try to go with the very direct questions for Dr. Brilakis because he's staying, I think, so we committed him to stay with us only for an hour. So Ahmed, please.
Okay, thank you very much, Dr. Cortes. Dr. Brilakis, thank you very much for the lecture. I have a couple of questions related to the CTO intervention. So we are currently not doing ischemia assessment like SPECT or PET before CTO. Not regularly done.
Yeah, and you don't necessarily need to, right? So the question is the ischemia testing. If you have a patient with classic angina, single vessel CTO, you don't need ischemia testing because there's no other reason. Where the testing for ischemia and viability comes in, it's in patients with cardiomyopathy, especially when they have as their main symptom dyspnea. That's when it's sometimes very hard to distinguish, okay, is the dyspnea an angina equivalent or is it just pure heart failure? And that's where the ischemia and viability comes into place. So, I would say most standard patients don't need ischemia testing. And now these days, what we're seeing here, and maybe you're seeing that in Cleveland and other places as well, we're doing much more coronary CT as the initial test. The stress testing is decreasing, the CT is increasing, and we have much less ischemia testing. But again, it doesn't matter as long as you have classic symptoms. But for people with ambiguous symptoms or shortness of breath and cardiomyopathy, absolutely, this is very important.
Okay, regarding the second question, the preferable axis at the second axis, radial or femoral. Some use radial and others.
Yeah, I can tell you the most common axis configuration is femoral radial. It's right radial, right femoral. Typically, at least for us, 8 French on the groin and 7 French slender on the wrist. But if we have really complex cases, bypass, supercalcified, previously filled multiple times, the bifemoral does give you the best support. Yes, you can get it done most of the time, but if it's a really challenging case, I still think bifemoral might give you a better support. If you have previous CABG patients, you can do the left radial snuff box, get the arm over the head, over the abdomen. The issue there sometimes is with obesity, it's really hard to get the arm far enough over there. But yes, I mean, you can do biradial if you want, you can do femoral radial, femoral doesn't matter. The key thing is flexibility. If you start with radial and you're having 10 minutes to engage the coronary, well, guess what?
Yeah.
Probably just move on.
Makes sense. Sandeep.
Thank you very much.
Thank you so much, Manos and Bernardo, for this amazing lecture. Really enjoyed it. I've got 2 questions. One quick one. So this is the vein graft PCI. Now, a lot of the time, your colleagues fix the vein graft when they come in with acute MI, as you said, you have to do it. But if the vein graft is very smooth and just a discrete lesion has been fixed and rest of the vein graft looks healthy, would you still bring them back and do the CTO of the native artery, or would you do a CT follow-up for these patients?
Yeah, no, and all of it, what I was showing you is for occluded grafts. So the graft comes in is occluded. When the graft is occluded, it's very bad prognosis.
Yeah.
If the graft comes in and the graft is a focal lesion, and you can stand it, then most of the time, the risk of doing that is less. And then you can see if they have recurrent restenosis or adhesions, then yes, maybe, but not necessarily. So we're not saying for every vein graft lesion, hey, just open the native, because these CTOs also are pretty risky sometimes, and bypass folks have more calcium, more tortuosity, so this can be much harder to recanalize than other CTOs. So for simple focal vein graft lesions, most of the time fix the vein graft and then see how the patient does. Now, if he restenosis 2 or 3 times, then yes, then you should open the native so we don't have this repeat PCIs.
Perfect. One last question is the HDR. I hear you mentioning that it catches the true lumen sometimes. Now, which patient selection you go for HDR, like lesion selections? Is it short lesions, or calcified? Because I've only done twice now, and both time I failed. Maybe it's the way I'm doing it, but I just want to know your opinion on that. I know it's very early on for everyone with this technique.
No, absolutely. I can tell you, we used it yesterday. We had it instant. We've done probably 40, 50 cases so far here. Where it works the best is instant.
Yeah.
You have instant that really, I think maybe it's the framework, maybe the stand has scarring on the wall. So yesterday we had an instant. I mean, literally went through to true within 2 minutes. Now, maybe the wire would have as well, but it works really well instant. If you have a 100 millimeter heavily calcified tortuous CTO, forget it. I mean, like anything else, I mean, it may get you started, but don't expect to cross a super complex, super long CTO with HDR. So instant is the best, relatively short occlusions. These are the ones that works the best. But again, sometimes it doesn't necessarily give you the crossing, but gets you started, you get halfway through, and then you do some other things to get completely through. So it's one tool. Again, it's not for everything. If you look at the Arraig's paper, he says success 100%, but these are selected cases, right? So it's not for everything, but it's one tool that can be useful in many cases, not all of them.
As you said,
it's a work in progress, HDR. You know, we are always learning. I adopted it for the first time like only 7 or 8 months ago, and I only did like 20 cases. I fully agree. So the calcific lesion is not a good, starting point for that if you want to stay into because the goal, as you, Sandeep, were saying, is to stay in the true lumen. And in the paper that we published, Manos Ivus was showing that we were able to stay in the true lumen like in 83% of the cases, which is pretty good, as compared to other modern techniques where the threshold of going for ADR is much lower. So this is the goal, but calcific lesion, I don't think is a good starting point.
Thank you so much. Thank you.
Thank you.
Vakas?
Yeah, thank you very much for your excellent presentation. I have one question. Coming back to our DCB topic for CTO, once I did integrate ADR for one of the lesion in the RCA, my wire was extra plaque and then coming out into the true lumen. So any experience of using DCB in this such scenario, in when the wire is some extra plaque and coming into the true lumen, and after preparing the vessel, you can go for DCB in this case, especially the lengthy lesion, we are opting for DCB.
Yeah, so obviously it works best if you are intraplaque, but even for the investment procedure I mentioned before, so the drug actually may be even more important in the extra plaque because the risk of free stenosis is higher there. But the key question is, do you get a good result or not? Yeah. So if you try the DCB and it looks decent and you have good flow and not huge dissection planes, then it's fine. But if you do this and you have TIMI1 flow and million dissection planes going all over the place, that's probably not the best. Then you probably understand to tack up the dissections and minimize the stenosis. So it all depends, like everything else. What I would do is very good preparation. So get get regular balloons, make sure that there's good flow and looks okay, and then finish it with a DCB. If after predilatation, it's not perfect, it looks still dissected and ugly and not good flow, maybe the stent is the way to go.
Okay.
Yeah, we had several discussions on that, and I agree. If you have a long dissection, you should avoid using DCB, especially paclitaxel. With Sandeep and Bharat, and also with Wojciech, we are investigating the role of paclitaxel when it's delivered outside of the vessel, of the true lumen, not of the vessel, of the true lumen. And actually, it seems there is an increased risk of aneurysm formation. So if you have a short period where you go outside of the true lumen, it's not an issue. But if you have a long dissection, I think that stenting with maybe DCB just distally is the way to go. Rima. Rima, are you there? Okay, while Rima is preparing, we also have another information I want to share. We are presenting at TCT as a late break in science, the Piccoletto 10 study. It's just a registry. So far we don't have randomized data with the drug or the balloons. But Rima, excuse me, let me finish. So Rima, we don't hear you. Rima, let me finish. Yes. So we have this this study. It's 850 patients treated with DCB, and it's very important, like what Manos said earlier, which is that you don't have to, after reopening a vessel, to say, okay, I want to go with only DCB. In more than 50% of the cases, expert CTO operators went with DES plus DCB. So the role of DCB for CTO is not to remove stent from our armamentarium and use only DCB. The role is to reduce the stent length that you're using, because quite often, after also a short CTO, you have a diffuse disease dictum. So there, you should use a DCB to reduce and spare the stent length. But we will see how also Piccoletto 10 data are going. So Rima, you have, okay, Rima disappeared. Marco.
Thank you so much for this beautiful lesson, Dr. Brilakis. Thank you, Dr. Cortese, for organizing. My question is, today the main indication is the symptoms improvement, as you said. Probably this is a speculative question, but based on the randomized controlled trial that are awaited and evidence that will arrive in a few years, do you think that the indication for a CTO PCI will evolve in the next 20 years? So what can be the the next steps?
Yeah, thank you. So there are two things that are, I mean, in terms of indications, the two key studies is to do like an orbital-like study, like a placebo or a sham control study. So that's the thing that needs to happen. There's a small orbital CTO. We were doing one, but got stuck with the pandemic. That's the one study that can just solidify, hey, yes, you do improve symptoms unequivocally, which we all believe it does. In terms of the hard outcomes, even with the ischemia CTO, I mean, to get a study to show you hard outcome improvement in stable CAD, you're going to do several thousand patients, which is highly unlikely to happen. And also what's happening in those studies is selection bias. The really symptomatic or really sick patients, they don't go in the study. Either the patient refuses or the referring says, you know what, I don't think it's going to study, and they do the procedure. So the ones who come in the study are typically the less symptomatic ones, the less sick ones. And then the problem is then you need many, many more to show a difference, because their baseline risk is so much lower. So that's been the challenge of CTO, and I think most stable CAD complexity studies.
Thank you so much.
Rima, you have your question?
Yes.
Do you have a better connection, please?
Yeah. Okay. Thank you so much for this presentation, dear doctor. I have one question. In which type of CTO lesions should we use the IVUS to help us to cross the proximal cap?
Yeah, thank you. I mean, to be honest, in terms of IVUS, and I didn't show intravascular imaging in general, it's done pretty much in most, if not all, the vast majority of cases. It's done for optimizing the result. In terms of crossing, it can help you in a couple of ways. One is the proximal cap ambiguity, to clarify that. If you have a side branch next to the proximal cap and you don't have much calcium, because if you have calcium, you cannot see very well. If you have a side branch, not much calcium, you can put the IVUS there and then help guide your wire into the intraplaque segment. Also, you can use it to re-enter. So let's say you go extra plaque, you can use the IVUS to do the tip directed. So you use the IVUS to understand where your tip is and direct the wire tip towards the true lumen. The latter one, that tip detected IVUS, it's a little more complicated. You have two operators. One is going back and forth with the IVUS to understand where the wire is. So it does require some training and expertise, but again, extremely useful. And it's almost done, again, most in the US, most centers use it nearly all the time for stent optimization.
Yeah, I agree. And we also have a few cases where CT scan is able, one just yesterday, is able to tell us about proximal cap ambiguity on where to go. So I think that the hour is unfortunately has come to an end. I want to tell you guys that this manual of chronic total occlusion is an amazing book. So this is why I just decided to buy with DCB Academy 3 of it, and we will create a contest here at DCB Academy, and the first 3 that will classify for the contest will have this book for free, because it's on my desk, and I quite often, almost every week, reopen it and go and read something. So that's a really beautiful manual. You can learn everything from CTO, A to Z. That said, Manos, really, really, it was an honor to have you here, and a pleasure on top of that. And thanks a lot. We will reinvite you. Be sure about that.
Well, thank you so much. Again, it was wonderful. Thank you so much. And thanks for everything you do for the CTO and the DCB area. So thank you so much.
Thank you.
Thank you.
Take care, guys. Bye-bye.
Thank you so
Thank
much.
you. Thank you. Bye.
Yep.